next speaker will be Professor Ahmad Alrubaie, who is a consultant gastroenterology and therapeutic endoscopist. He's associate professor at University of New South Wales, and he is currently, all know, president of the Australasian Medical Association. He also has started work in Australia from 1995, and he was awarded the Fellowship of Royal Australian College of Physicians. And now currently he's working in Bankstown Hospital, and he is also a senior lecturer at the University of Western Sydney. So welcome, please, Professor Ahmad Alrubaie.
Thank you very much. I might use this slide because I move a lot during this. Thank you for this opportunity. Now, my topics today would be on the endoscopy in the management of obesity. Now, a few years ago, when I have similar presentation, I have this profile of the management of obesity using different modalities and different disciplines. And you can see with this, the least in terms of effectiveness is the lifestyle modification. And the most effective ones, as usual, the surgery as a gold standard. And you can see that I have the drugs as the second less effective way, followed by the endoscopic treatment. Now this year, after all the advancement in the pharmacological treatment, I changed the sequence. Sorry, how can I get back? So you can see here that the pharmacological treatment now is matching the endoscopic efficacy there, and sometimes some numbers are exceeding the endoscopic treatment, and surgery continues to be the gold standard. Now, the major question here is it the efficacy or the reality? Efficacy, is it the measure when we choose a modality to help obesity? Do we go for surgery as the most effective measure in the management of obesity? I think it's a reality, and there are many, many facts for that. The most important one is that we are dealing with a pandemic. We are not dealing with a prevalence of a disease. There are around 2 billion persons now with obesity, let alone overweight. So reality dictates the selection and the needs. We have also the spectrum of obesity, and as you can see from this, that the BMI more than 40 is the least among all other BMIs in terms of the management, and then selection also will take into consideration this pyramid. Now, the big question, is there a place for bariatric intervention? There is no item numbers right now for any of the bariatric endoscopic management of obesity. Dr. Mad presented excellent data on the breakthrough by the pharmacological agents in the management of obesity. But let us be realistic. The tolerance is a major factor here. 30% drop either because side effect or because of the cost. We have several contraindications, and the durability is limited. Once you stop it, 2/3 of weight is regained within 1 year after stopping it. So these are all limitation factors. Surgery. We know surgery is the gold standard. The BMI, or the total body weight loss, is ranging anything between 25 and sometimes 30 or 35. But is there access to surgery? In 2023, the American Association of Bariatric Surgery estimated that there were 250,000 a sleeve gastrectomy and bypass done in America in 1 year. So if we consider the number of obese patients in America, this means they need 400 years to treat their obesity for the current number, let alone the increasing number. So access is a major problem to use the efficacy of the surgery. Access even by the financial restriction, because not everyone can afford it. Contraindication, we have contraindication. We have people who are unfit. We have people who prefer not to have surgery. We have people who are aware of the morbidities and mortalities of surgery. And the third factor is the weight regain. And I think Dr. Muhannad will present some data about weight regain and the revision there. So for this reason, limit the use of the surgery. Now, bariatric endoscopy simply, it's a wide range of procedures. All are oral, all using the gastroscopy, all are minimally invasive, almost all are reversible, and all are with the day only. So there's no admission. There's no admission. Generally speaking, all of them are gastric in terms of intervention, and the duodenal one are very limited, and they are still in the advanced phase of research. I'll start, and there are two types. The gastric one are two types: the space-occupying device and the restrictive procedure. And the space-occupying device, we know the intragastric balloons, which was established or introduced in 1985 in a very primitive way. Now, the effect is simple. So first of all, it reduces the volume of the stomach. Secondly, it delays the gastric emptying. Thirdly, it gives the feeling of satiety because of the limited volume. And also, there is a very, very mild neurohormonal effect through the stretching, affecting the ghrelin and affecting the leptin hormones. Behavioral modification depends on the development of habit. When you have a heavy meal with a smaller stomach, you will have vomiting. You will be punished on that. So hopefully this will establish some habit. Now, the main eligibility, BMI 30 to 40, but BMI of more than 27 with comorbidity is another indication. We have several types of intragastric balloons, but we ended having two only. The most common one, two are the Orbira. This is the intragastric. By the way, introducing the capsule is a very simple procedure, 10-minute procedure. And in this case, we introduce it and dislodge it and come out. It is widely used in America for a reason we can't understand, because it should be pulled out in 6 months. So after 6 months, we go there, we puncture it, and then we pull it. The second one is the spats. This is the most widely used. This we fill it through the scope, and it is the only adjustable balloon. So it can be adjusted according to the response. With less weight loss, it can be increased. The volume can increase, say, from 500 mils to 700 mils. So it is adjustable. If they are vomiting, we can reduce that. And it is 12 months. Now, the average weight loss here, total body weight loss, is 12 to 15 with the Orbira, 17 to 18 with the spats. That's on top of the multidisciplinary approach, where we involve a team of dietitians, psychologists, exercise physiologists, and a specialized general practitioner. Now, the durability is very limited. In few months after removing it, more than 50% of the loss will be regained, and in 1 to 2 years, almost there's nothing apart from few kilograms. Now, the second type of intervention is the restrictive procedures, and there are many types, but we ended having this procedure, which we call it endoscopic sleeve gastroplasty. So this procedure is introduced in 2013, and it's based on suturing, have 4 to 6 sutures, starting from the incisura in the intrum, going up through the greater curvature. So by 4 to 6 suture lines, the size can be reduced to by between 70 and 75%. And the stomach ended, so that is the normal bag of the stomach. But with the suturing, we end with a tubular shape similar to the sleeve in terms of the shape. Now, the mechanism of action is, first of all, again, it's reducing the volume of the stomach. Secondly, it delays the gastric emptying, and the sutures are placed in a way that it affects the propagation of peristalsis, causing less emptying. Early satiety, that's by stretch receptors. Hormonal modulation is very effective here, so both the ghrelin is decreased and the leptin increased. Leptin suppress appetite, and ghrelin is the hunger hormone. So the ghrelin is suppressed, there's a bad fit. And again, we have the same behavioral modification by the habit, developing a habit. Yeah, thank you. That's good. Now, the eligibility is BMI between 30 and 40, and BMI more than 27, but with the comorbidities, diabetes, uncontrolled metabolic syndromes, and also obstructive sleep apnea. Now, the outcome, don't worry about this iteration, it's in the region of 18%, and sometimes some studies, some centers move it to 19%, but it's definitely less than 20%. That is the outcome. Durability. Durability is it dropped by a few percent. So between 14 and 18% at 2 years, and at 5 years, it is not more than 15%. I think Dr. Mohanad would present some data about the durability of the surgical intervention. Now, I'm talking about the further advance. One of them is still going on through a study here in Australia. Those suture lines can be treated with argon plasma coagulation to make or increase scarring on the line of suture. And this increase the stiffness and affect the emptying, gastric emptying. That's one. The second one is if you join it to one of the pharmacological agents. And that, in fact, there is a recent study which showed that the total body weight loss would be between 20 to 25% if you add one of the other pharmacological agents. And that wasn't a recent one. In 2018, I was in Spain, in Madrid, with Professor Lopez, who introduced this technology. And even then, he was using Saxenda. But the American wasn't agreeing, wasn't adding this to the evidence about the efficacy of the ESG. Now, this is about the ESG. We do have further endoscopic role in the management. Dr. Mohanad would talk about the bypass. Sometimes the weight regain is due to the diameter of the anastomotic site. So we can do endoscopically a reduction of this size by what we call it endoscopic submucosal dissection, and then suture it. And we can reduce the diameter. And this would be a non or minimally invasive way of managing weight regain. Now, there are a few things going on, like gastric fundal ablation or myotomies. All these are in this stage of research. Now, a few words on metabolic endoscopy. Now, endoscopy can be used in managing advanced metabolic disorders. So not necessarily for obesity or overweight, because metabolic disorders, as you know, can occur even in lean people. So fatty liver disease is occur in about 6 to 8% of normal weight or BMI people there. So there is now increasing use of endoscopic intervention in the management of poorly controlled diabetes or metabolic syndrome, and also in fatty liver disease, which is now the major liver disease. The most common liver disease or cause of liver disease is this one. Now, with this, I end with the duodenal interventions. So duodenal interventions are the intervention used in this metabolic endoscopy. There are quite a few of them. Most of them are in advanced stage of research, except this modality and this modality, where it is mucosal resurfacing. Through a balloon, there are needles which transmit a warm fluid to destroy the villi in the area. And this is considered as a mini bypass surgery because this includes about 10 to 12 centimeters of the distal duodenum, which affect the absorption. I think that, this is very promising. So this is an endoscopic bypass. It is still in early phases there, where a double balloon endoscopy can be used in deploying a magnet in a loop of the jejunum, so that it serves like a fistula. And this can be later on turned into a bypass there without any surgical intervention. This is still in the advanced phase of research. Thank you very much.